Welcome to the virtual APSA 2021 Presidential Symposium entitled, Are We Training Too Many Pediatric Surgeons? I am one of your moderators, Dr. Samuel Elish from Johns Hopkins University.
And I'm Dr. Abigail Martin from Nemours AI DuPont Hospital for Children.
We are the chair and vice chair of the APSA Workforce Committee, and we are delighted to be part of Dr. Waldhausen's Presidential Symposium that will debate training, workforce, and competency issues as outlined in the Right Child, Right Surgeon initiative. We are truly fortunate to have 4 outstanding speakers on our panel. The format will be as follows. There will be 2 5-minute presentations, each on the pro side of the argument, followed by 2 5-minute presentations, each on the con side. Then there will be 4-minute rebuttal time for each speaker. Finally, Dr. Martin and I will ask a couple of questions to the speakers to answer unchained from their position in the debate. So that way we can see what they really think.
Leading off our debate and taking the pro side will be Dr. Mary Brandt. Dr. Brandt is professor of surgery at Tulane University School of Medicine.
Hello, friends. I am so happy to be here with you today and start this debate on what is a very important question for our field, which is, are we training too many traditional pediatric surgeons? It does depend whose eyes you're looking through. So for our trainees and for all of us in practice, it's, will I match? What will my job look like now and in the future? Will it be fair? Will it be meaningful? And will I be able to find partners to join me? But for the children we take care of, their questions are more like, is there a surgeon where I live? Are they well trained and up to date on caring for my condition? If they aren't, can I be moved to a different place for my care? And maybe the really hard question, are there decisions about my care that are driven by money rather than by what's best for me? And so that becomes an ethical question, and that requires an ethics workup. And this is a process developed at Baylor College of Medicine that I've adapted to the ABC format that we're familiar with. And so it's 5 steps. It's assess the information, who's involved, what do we know, what do we need to know. B is for box, but the second step is really what's the either or. Are we training too many or aren't we? And then the real part there is to think of what's the third option, 4th and 5th, because that's more often where we find the answer. Consider the appeals. What appeal do we make for our argument? And I'll walk through, there's 5 different appeals that I think apply here. And then you decide, you take all of that, you put it together and say which has the heavier weight, which is the more decisive answer based on this whole process. And you end with how you could have prevented it. So who's involved? Well, for this debate, it's clearly patients and their families, the pediatric surgeons, and society. There are a few others, but I think those are the ones we really should consider for this debate. What are our choices? I really think the 2 options are to keep doing what we're doing or to train fewer traditional surgeons and more acute care surgeons. And if we were to step out of that box, out of that binary, what else might we think about? Should we have more pediatric surgery training in rural and global surgery tracts? Should we provide an additional 6 to 12 months training for any surgeon who desires to be competent in basic pediatric acute care surgery? Should we create a Teach for America model or Operate for America, where new grads are paid to spend 3 to 6 months in neglected, underserved communities? We as a society are paying a lot of money to middlemen for locum tenens in pediatric surgery. That's coverage that's actually needed if children are going to get care all around the country. So what if we organized that? What if APSA did it instead of paying all this money to middle people? And what about a different model rather than a fellowship position for busy pediatric surgery centers so they have needed support and can participate in the joy of educating people who want to take care of children with surgical diseases? And I suspect if we brainstormed, we'd come up with a whole lot of other ones. So then we consider the appeals. And this is a process where we ask basically 5 things. First one is there a rule? Is there an established legal, ethical, professional standard? Then we appeal to consequences. Is this decision going to be a big deal? And is it likely? And is it really going to hurt people? We appeal to the rights. Who has the right to practice? Who has the right to do what? And then the virtues. So which way's the best way to go in terms of compassion and courage and all the things that we know matter to us as human beings? And then finally to justice. And when I add all those together and I create that process of weighing the pros and cons, what's in favor of a change, excuse me, is serious and likely consequences for children, surgeons, and society if there's no change. It's in line with the rights of children to not be harmed, to have access to high quality care, and to have normal development and a normal appearance. It appeals to the virtues of compassion for the children, courage on our part to make a big change, self-sacrifice because we probably are going to lose income and have increased work during a transition, and fairness. This is more fair for all children. We can appeal to justice in terms of meeting a basic, decent minimum of care for all children. Now, in favor of the alternate argument to stay where we are right now, we can appeal to compassion for students and residents who may not be able to train as pediatric surgeons but really want to. And we can appeal to the legitimate self-interest of surgeons and institutions to control their practice, their income, and how they practice. But when I add all that up and I look at the pros and cons and go through this process, which one of these has the greater weight in terms of an argument? And I think the answer is clear. Are we training too many traditional pediatric surgeons ethically? The answer is a clear yes.
Thank you, Dr. Brandt. Now, Dr. Robert Ricca will expand on the pro argument. Dr. Ricca is a retired captain of the United States Navy and currently practices in Greenville, South Carolina.
I would like to thank Dr. Waldhausen and Dr. Alaish for the opportunity to speak on this important topic today. I'm honored to be part of this conversation with these distinguished panelists. The question, are we training too many pediatric surgeons, affects every one of us, no matter what type of practice we are in. This is a complex topic, and I would like to start my discussion with a simple review of the numbers. In the 2010 United States decennial census, there were approximately 74 million children. These were defined as individuals under the age of 18. While the number of children is at an all-time high, the percentage that children comprise of the United States population is at an all-time low. This has slowly decreased from 40% in 1900 to 24% of the population by 2010. The number of children only increased by 3% from the 2000 census, when there were just over 72 million children in the United States. While we eagerly await the 2020 census data, we can use population estimates to see if there has been any growth. The expectation is that in the 2020 census, the number of children in the United States will remain steady at 74 million and will comprise only 22.2% of the population. It is believed this trend will continue, with an estimated population of only 76 million children by 2030, comprising only 21.3% of the population. This data directly impacts the number of surgical cases available to pediatric surgeons. It is a main driving force for our professional growth. Now let's focus on the surgical workforce numbers. We can examine the period of time surrounding the decennial census to see the impact of training programs on our workforce. Using the pediatric surgery genealogy text, we find that there was an additional 14 pediatric surgery training programs in the United States and Canada added between 2005 and 2015. This increased the number from 39 to 53 programs. At the same time, several programs also increased the number of trainees. The result of this was a doubling of pediatric surgeons from just over 400 in 2005 to 835 by 2015 in the United States. Our ratio of pediatric surgeons to children based upon the U.S. population has changed dramatically from one surgeon for every 183,000 children in 2005 to one surgeon for every 88,000 children in 2015. Since that time, there have been 3 further programs added, only increasing the number of graduating surgeons. Despite this expansion, one must ask if we are meeting the needs of our patient population. Efforts over the years have focused on regionalization and subspecialization, with an emphasis on improving surgical outcomes. However, have we focused on access to care and reacted to the population shifts of the children we serve? Our research shows that in 2010, over 10 million children in the continental United States lived in rural areas. Pediatric surgeons, by and large, practice in urban centers, leaving these 10 million children greater than 60 miles away from the nearest pediatric surgeon. The U.S. Census uses rural-urban commuting areas to determine whether an individual lives in a metropolitan, micropolitan, or rural area. Looking at the 2019 APSA membership list can provide a good cross-section of early, mid, and late career surgeons who graduated during the 20-year time period from 1996 to 2015. The data shows that 98% of these surgeons practice in the most urban environments. Compare that to the fact that our research and other similar evaluations of the population show that only 80% of children live in these corresponding urban areas. It seems clear that the answer is yes. We are training too many pediatric surgeons. The population we serve is not seeing significant growth, and we focus our resources in the most urban areas, potentially not addressing the needs of rural families. With a continued increase in pediatric surgeons in the workforce, this will lead to potential issues with surgical case volume, issues that have been raised addressing competency, especially with congenital and other complex cases. Furthermore, while we provide outstanding access to care for over 60 million children, there are 10 million children that we are potentially not providing equitable access to care. Our pediatric colleagues are focusing on rural health, and while not all of these children may have surgical concerns, we need to ensure that when a surgical issue arises, we have the right surgeon for each child. These children may not require a fully trained pediatric surgeon for an appendectomy or cholecystectomy, but may be better served by a rural surgeon comfortable with caring for children, allowing them to remain closer to their primary care providers, specialists, and families. Furthermore, the rural surgeon caseload focuses on these types of procedures, making them well qualified to provide this care. We have many challenges to face as we address our surgical workforce. However, I believe our finest hours are yet to come as we continue to be the leaders in surgical care for children around the world. Thank you.
The pro side has made its case. Now it's time to hear the other side of the argument. Dr. Edward Barksdale will begin. Dr. Barksdale is Surgeon-in-Chief at Rainbow Babies and Children's Hospital and professor at Case Western Reserve University. He is also on the APSA Board of Governors.
Are we training too many pediatric surgeons? I would like to say a loud and emphatic no. It was the great American statesman Tip O'Neill who stated that all politics is local. I believe the same is true for healthcare. All healthcare is local. What applies in Baltimore does not necessarily work in Boise. Likewise, the expectations in Chicago may vary greatly from those in Chattanooga. I have seen this for myself working in Boston, Cincinnati, Pittsburgh, and Cleveland. When you've worked in one academic medical center, you have only worked in one academic medical center. So I would like to first caution us as individuals in this great subspecialty working in our regional microenvironments to avoid the myopia, chauvinism, and maybe even the subtle arrogance that we know what's best for the diverse communities and patients that we provide care for across the country. As an experienced pediatric surgeon in one of the nation's most competitive children's healthcare markets, 3 children's hospitals, 1 children's unit in a 40-mile radius, I witnessed firsthand the intense market pressures for the decentralization of children's surgical care to satellite, suburban, exurban, and rural facilities for the benefit of the much larger healthcare goals of the system, capturing market share as well as revenue for these hospitals. This strategy diminishes the value of what we bring to the table as pediatric surgeons. Often there is a mindset that we are just general surgeons for children. Many of us have witnessed the horrible consequences of cases performed by adult general surgeons operating on children. Upon my arrival to Cleveland 14 years ago, There was an accomplished adult general surgeon working in an affluent Western suburban hospital with 20 plus years of experience, performing elective hernias, orchiopexy, appendectomies, gallbladders, and colon resections on children. But it was some of the smaller cases, such as abscess drainage, that were really horrendously managed and treated. His work continued through the support of our institution because patients in that area were reluctant to drive 25 minutes to our urban location. This approach undermined the value of pediatric surgeons in our system who relied on the bread and butter cases to fulfill the productivity expectations of the system. Those of us who work in highly resourced major children's hospitals or academic medical centers are able to creatively support specialization and subspecialization. However, the vast majority of us do not work in highly resourced or heavily endowed standalone children's hospitals. And we need to do it all as generalists in order to meet our productivity metrics. We work in a unit, a hospital within a larger hospital, or in institutions that are components of a network or system that controls, manages, and dictates what patients will be cared for and in what locations. The introduction of another category, or even worse, more categories of pediatric surgeons to perform the so-called mundane cases on children will unwittingly create competitors, as some institutions or networks will encourage these pediatric surgeons to push the envelope of age and case complexity. I believe that the proposal may also introduce the concept that adult specialists in colorectal, thoracic, and even minimally invasive surgery should be operating on these small adults. I find the term mundane used in the manuscript reference to relative to complex cases as pejorative for the pediatric surgeon, as I fight in my hospital that we are not just the pediatric general surgeons, we are the pediatric surgeons. There is more than just a subtle distinction, in my opinion. I believe that we as pediatric surgeons are trained on the foundation that we care for children with surgical diseases. I'm profoundly concerned that the proposed new paradigm of defining pediatric surgery and pediatric surgical training will narrow the scope of our practice, influence, and our impact. We should not allow our contributions as surgeons to be whittled down to our technical expertise in complex tertiary procedures performed in children over the more holistic value that we add to children and their families in surgical health care. The concept of right child, right surgeon leaves out the equally important component of right place. Our outcomes are heavily dependent on our recognition that we work in collaboratives with other pediatric subspecialists, staff, and facilities. The development of additional categories of pediatric surgeons will encourage greater risk taking by surgeons to operate on children in venues where they are ill equipped to provide appropriate care. So, in closing, I say that we do not need to redefine, but rather refine what it means to be a pediatric surgeon. We are not training too many surgeons. I feel we need to continue to embrace our responsibility as scientists, clinicians, educators, and even administrators, but most importantly, as the vanguards of children's surgical care in this country. Thank you.
Thank you, Dr. Barksdale. Dr. Douglas Barnhart will now close out the initial arguments. Dr. Barnhart is professor of surgery and the training program director at the University of Utah. He is also a director on the American Board of Surgery.
Good afternoon. Thank you for the chance to discuss this important topic. The Right Child, Right Surgeon initiative identifies several important problems. First, it correctly identifies that there's a maldistribution of pediatric surgeons and that there are children who do not have ready access to pediatric surgical care. Secondly, it identifies that general surgeons are receiving less training in pediatric surgery and care for less children in their practices. Thirdly, it acknowledges challenges with maintaining competency in low-volume complex care if there's an increasing number of pediatric surgeons. Unfortunately, it proposes an incorrect solution. In response to the question of this debate, are we training too many pediatric surgeons? I would like to ask APSA's membership two questions. First, in a country as developed and wealthy as the United States, do all children deserve the same level of pediatric surgical care, regardless of their location or economic status? There is no debate that they do, and I know those arguing the other side concur with this basic principle of equity. The second question is equally simple. Who are the right surgeons to care for children's general and thoracic surgery problems? Fully trained, board-certified pediatric surgeons is the obvious answer. Before we address some of the challenges we face, I want to remind you of what lies behind the phrase fully trained and board-certified pediatric surgeon. In addition to their primary teaching faculty, three principal groups participate in the development of pediatric surgery trainees. The review committee of the ACGME provides specific requirements for fellowship programs and verifies the program meets the requirements and that fellows are being successfully trained. The Program Directors Association creates curriculum materials and develops educational resources, courses, and assessment tools. The Pediatric Surgery Board establishes minimal required operative case experience and provides a rigorous exam process to assure graduates have been appropriately prepared for independent practice. The board also assures ongoing competency. Each of these groups brings a unique perspective and ability to assure that we're producing capable pediatric surgeons. While we can argue about the details of how each of these groups might fulfill its role more effectively, we should not undersell our final product. Each graduating fellow brings a specific and valuable mixture of knowledge, judgment, experience, and skill to help the children in the community that pediatric surgeon brings. What is the alternative to meet this unmet need if we train less pediatric surgeons? The Right Child, Right Surgeon initiative proposes that this gap be filled by acute care general surgeons who receive training to perform basic pediatric surgery. There are numerous problems with this, and my time is limited, so I will list them and we can debate them in more detail later. First, what is basic pediatric surgery? Is a laparotomy for necrotizing enterocolitis basic? This seems like an appealing thing for the local general surgeon to do to avoid the risks of transport of a very premature baby. After all, it is a simple intestinal resection and creation of an ostomy, presumably well within the technical skill set of a general surgeon. But what about the decision of when to operate in an infant with a worsening examination but no pneumoperitoneum? What about the infant who has extensive bowel loss and the need to prognose and guide the family? Without a fully trained pediatric surgeon, it seems like these important surgical decisions will necessarily be abdicated to the neonatologist. How about a bronchial-formed body? Pretty basic for a fully trained pediatric surgeon, not so basic for the general surgeon. An even more common example, how sick does a 4-year-old with perforated appendicitis need to be to merit a second operation? I'm not sure what basic pediatric surgery is or who will define it. Second, who will serve in place of the ACGME Review Committee, Program Directors Association, and the Pediatric Surgery Board? Who will set the curriculum? Who will assure that the programs are well organized and that trainees receive appropriate training? Who will verify that the trainees have mastered the material and had an adequate clinical experience? How will ongoing competence be assured for this small group of general surgeons doing children's surgery? Surely APSA cannot fulfill all these roles. This is too heavy a lift for a small organization of volunteers, which is already strained financially. Third, it is not clear that general surgeons or the acute care surgeons view providing pediatric surgical care as their responsibility, or the program directors will agree to replace other elements of their training programs with pediatric surgery. This is our problem to solve, not theirs. In closing, I want to ask that we look at creative ways to provide care for children by fully trained board-certified pediatric surgeons. All of us are using telehealth much more extensively. Families can often make a single trip for surgical care with preoperative and postoperative care done via telehealth. We can practice at the top of our license with the help of specially specific APP colleagues. Large practices can provide care in less populated areas on a rotating basis. For example, my division currently provides care in Montana in a sustainable way. Finally, we need to recruit fellows who are interested in providing care in smaller communities. These applicants exist, but they've not typically been favored by programs during the match selection process. Let's face the basic fact. Surgical care continues to evolve towards specialization, and in some areas, super specialization. A proposal to move towards encouraging surgeons who are not specialists in children's care goes against this trend. It would downgrade the care of children to less expert surgeons. All children deserve fully trained pediatric surgeons. Thank you.
Thank you, Dr. Barnhart.
Welcome to the live portion of our presidential symposium, where we will take the debate up a notch. We will begin with rebuttals from each of our speakers, starting with Drs. Brandt and Rika, followed by Drs. Barksdale and Barnhart. Dr. Brandt, you have the floor.
So I respectfully but adamantly disagree with my two dear friends and colleagues, Drs. Barksdale and Barnhart. I'll start by agreeing with Dr. Barksdale's assessment that the word mundane should be changed. Everyone that I've trained has heard me say that the only minor surgery is surgery on someone else. So I think we have to come up and commit together to have a new term as we're talking about this. But I also have to point out that the major part of Dr. Barksdale's debate was centered on the financial impact of a change. We have to consider the structure of healthcare systems and financial implications of our decisions, but they cannot be the core, the basis for this decision. Yes, we will create competitors and have decreased revenue from simple cases, but it's our moral obligation to think about more than these financial issues. If even one child dies or is harmed by not having access to care after trauma, we have failed. If even one parent loses their job because the nearest place of care for their child with appendicitis is 100 miles away, we have failed. Many of you know that I'm married to a pediatric hematologist oncologist, and I've come to believe that the model of caring for pediatric cancer is the model we should aspire to in pediatric surgery. Dr. Barnhart, the infant with NEC you discussed is like a patient with newly diagnosed leukemia. Of course they should be in the hospital and not in the community. But appendectomies in a 12-year-old and draining an abscess in a 3-year-old are different. If you will, these are like the iron deficiency anemia of PDHemonc. They may be seen in a quaternary center, and we would welcome them, but they don't have to be seen there. And if their local pediatrician has a question or a need, the experts in the quaternary center are there to help. It's not either or, it's both and. We have to create a functional network of care for this to work. Let's talk about another elephant in the room that hasn't come up yet. We are training people for 9 years to care for complex pediatric surgical disease, but because of the market pressures that Dr. Barksdale so accurately described, they're being hired to work in satellites, in suburban satellites of major hospitals, doing lists of G-tubes and central lines. We are not underselling our fellows, but we are not providing them the jobs they aspire to either. I'm aware, as are all of you, of current fellows and recent graduates who are struggling to find jobs, and others who are being paid huge salaries to sit in a hospital for a NICU to exist and doing less than 100 cases a year. The data from the American Board of Surgery is clear. This is not a limited problem. The vast majority of surgeons are not doing enough complex surgery to maintain competence for complex procedures, and that's another ethical issue we have to face if we're going to have equity of care for all children. Thanks so much for including me in this, and I can't wait for the discussion to continue.
Thank you, Dr. Brandt. Dr. Rika?
Great, thank you all. And I agree with Dr. Brandt. As you can see from my initial discussion, our primary focus as surgeons should be on the patient and their family, not productivity. We must advocate for equitable not just equal care for all our pediatric patients, no matter where they live. Let's look at the current system. Of the 8 areas that Dr. Barksdale mentioned in his opening, important, and research shows that the outcomes for rural pediatric patients are lacking when compared to urban patients. Rural children have higher prevalence of complex chronic conditions, higher inpatient costs, and higher readmission rates. Rural areas have been aptly named health deserts due to the sparseness of appropriate medical care. Individuals who live in these areas have high poverty rates, and yet we make them travel great distances for care, increasing expenditures, taking time away from work, finding time for children, and most importantly, receiving fragmented care due to the fact that their primary care providers and specialists may not work within the same area or even the same health care system. My colleagues carefully chose their surgical conditions to prove a point. I would ask, should a child have to travel 60 miles to have their G-tube replaced, passing countless hospitals along the way? This is a frequent occurrence in the United States today and adds an extra burden to the rural family. When you operate on these children, let's ask, who do you turn the care over to when discharged? Do you ensure communication with the local pediatrician or local surgeon? Or is the expectation that the patient must come back to the major academic medical center provided by our APPs and not even a pediatric surgeon? We use APPs to supplement care in our institutions rightfully, but wouldn't a system that uses a rural general surgeon to assist in the care of the patient within their scope of practice improve the overall quality of care for all these patients? One answer to these issues has been raised as telehealth, but telehealth has been shown in several studies to create disparity in care for multiple reasons, including language barriers and differences in cultural views of medicine, a solution approved by surgeons, but not necessarily by all families. Another answer is the provision of travel coverage or locums tenens by pediatric surgeons to small community hospitals, creating an itinerant surgeon model. These efforts, while important, do not provide a comprehensive solution. And from my own experience in the military and locum tenens, it's not clear that these are a viable, long-term, cost-effective solution. A rural surgery curriculum has been created and recently presented to the Board of Governors that includes entrustable professional activities with opportunities for standardized didactic education. We know that the exposure in residency to pediatric surgery has decreased over time. Our curriculum addresses both training issues and can serve as a resource for once the training is done. The discussion on board certification is a bit of a straw man argument. Pediatric surgeons were practicing for decades, and APSA was founded several years before one could receive board certification in pediatric surgery. And some of the most technically gifted surgeons in the country were not able to receive board certification until recently, and those are surgical oncologists and minimally invasive surgery colleagues. But the ABS now allows for a focused practice designation in bariatric surgery. Can't we create a similar rural surgery pathway under the guidance of APSA and the American Board of Surgery? Rural children need equitable care, and the answer is not our current model that creates a disparity in care. We can't let the US healthcare system prevent us from finding solutions that provide equitable care to all children due to financial concerns or bureaucracy. We can't abdicate our responsibility to ensure equitable surgical coverage to every child. This is the goal of the Right Child, Right Surgeon initiative. I will agree with Dr. Barnhart on one point, that this is a heavy lift, and 74 million children nationwide are counting on us to be the leaders in healthcare. Thank you.
Thank you, Dr. Rica. And now for the other side, Dr. Barksdale, it's your turn.
Colleagues, I am delighted to join you. It's always great to speak with people who are bright and have views, but I think that we have to be very careful, as I mentioned in my statement, that we think we know all of the United States and we know what's best for every region. We are a relatively small group of surgeons, 1,500. And even though Dr. Brandt says that my comments are based on issues of finances, in many markets, despite our passions, despite our abilities, our actions are dictated by markets. There are some of us who have left certain children's hospitals because the climate changes and we must move to other places. And my point is that when we are trying to decide what's best for a particular region, we have to work in concert with the healthcare systems, the providers, and the patients as to what works best there. Dr. Rika commented on Chattanooga being 500,000 people. He probably hasn't been to Cleveland, which is smaller than that. And there are 3 children's hospitals and yet another unit. And so my point is that our perspectives of what is an urban area and what is not an urban area may be very different. You might also not realize that 25 minutes from Children's Hospital is Amish country, which is as rural as any place in the United States. And so we have a certain perception that we understand what every region is about and what every region needs. So my philosophy is really that I think that we need to ensure that we have adequate care of children. I believe in the concept of equity, not just ethnically, but geographically. And we must ensure that we help develop rural programs. I would also argue that in our market, the patient 100 miles away, when the G-tube falls out, they walk to the next room and they get the spare G-tube and put it back in. They don't drive to us. They don't even drive to their pediatrician because we have educated them to be self-sufficient, which I think we need to do, as Maria Cho so aptly mentioned in her presentation. So I think we have to think creatively about how we empower our patients, but also how we empower providers and regions. And I don't think it's a heavy lift for a surgeon taking out appendectomies in adults to do this in rural areas. And if they have relationships with us, just like we have with our patients, we can walk them through things. I do think this is an area of important dialogue and discussion. And even though I don't think we're training too many pediatric surgeons, I also feel that we should not be increasing the numbers of programs and that we should look furtively as a group as to how we can ensure the provision of care. The final piece that I state is that, when we train people who are able to operate on children in rural areas, many healthcare systems will see that they can be credentialed to do pediatric surgeons in our market. That brings down the quality of care and safety. So I think the problem is much more complex than just right surgeon, right child. And I think that we need further discussion. I'd like to thank everyone for their insights. I've grown from hearing the opposition remain steadfast.
Thank you, Dr. Barksdale. And rounding out our rebuttal segment is Dr. Barnhart.
Good afternoon. It's good to see my friends, even if only virtually. I want to thank them for raising several important issues that we need to address as a specialty. But first, I want to point out to Rob that you use desert like it's a disparaging term. And as somebody that bikes and skis in the high desert, that's one point you've lost. I especially appreciated Dr. Brandt's ethical framework for how we should consider this problem. Thank you for focusing us on doing the right thing. I do not, however, agree with your analysis. I do not believe that providing care by lesser trained surgeons to rural children is how we achieve equity. I know that is not your opinion either, but it is an anticipatable outcome of your position. There's no doubt that we face complex questions. We do need to solve these challenges to provide excellent care to all children in our country, but we need to be realistic as we seek to do so. I would like to inject a bolus dose of reality into this discussion that will hopefully sustain us through the remainder of our deliberations. Here comes the bolus dose. There is no one in the US who has the authority to decrease the number of pediatric surgery fellows. Full stop. One more time so you get it. There is no one in the US who has the authority to decrease the number of pediatric surgery fellows. Appropriately, the Pediatric Surgery Board will certify all qualified surgeons regardless of workforce needs. The ACGME will approve all programs that meet requirements, and the Program Directors Association will welcome and assist directors of new fellowship programs. All of these actions are appropriate to their missions. APSA can debate, but it cannot regulate the number of fellows. These fellowship programs are not funded by federal CMS dollars or by the Children's Hospital Graduate Medical Education Payment Programs. Therefore, there is not even a government mechanism for control. The simple fact is that we will continue to train more than 60 fellows a year, and this number is likely to increase. This will continue until market forces discourage young surgeons from entering our specialty. To be clear, I do not take pleasure in this observation, but this is the reality. We need to face this reality as we seek solutions. The proposal to train a subset of adult general surgeons to do a subset of operations in children's must be assumed to be an ongoing increase in fully trained pediatric surgeons. It is therefore a mechanism for formalizing inequitable care, and it is unnecessary. Market forces are already driving newly trained pediatric surgeons to take positions in less populated areas. The job market is increasingly tight. This has already been acknowledged by the other side. Ask any program director how much they worry about whether their new graduate will find a job. While this may be stressful for new graduates and program directors, it does mean that children in underserved areas will increasingly have access to fully trained pediatric surgeons. It therefore seems like the better option under Dr. Brandt's ethical framework. In light of these realities, let's be smart as mentors and programs. Let's encourage young surgeons who desire to be in smaller cities to pursue pediatric surgery as a career. We need to change the phenotype of the ideal candidate to include those who are interested in clinical careers outside of academic centers. We can match surgeons who want to be in smaller communities. We simply need to give this weight rather than only considering research experience and academic ambition. The issue of maintaining competence with problems with an increasing specialty workforce is real. For the sake of our patients, we need to address this. But this is what we do well as APSA. Providing ongoing education of pediatric surgeons is what APSA does best. Maintenance of competence at our level is more about judgment than technique. APSA has embraced the principles of adult education and helps all of us stay current. This will continue to develop even further with the innovative approaches APSA leadership has encouraged. We need to maintain our focus on this, especially as the number of fully trained pediatric surgeons increases. Developing a curriculum, verifying training programs, and certifying individual competency for partially trained children's surgeons who care mainly for adults is a distraction for APSA from this important mission. It is also unnecessary. Even if we all agree that we should decrease the number of pediatric surgeons, there's no mechanism to do so. Let's not muddy the waters with partially trained surgeons being encouraged to operate on children. I hope we can discuss our discussions on not only the important, but the possible. Thank you.
Thank you, Dr. Barnhart. Next, Dr. Martin and I have a few comments and questions for our speakers, who are now free to abandon their assigned debate position if they wish. I start, for our panelists. Based on Dr. Rika's data and Dr. Martin's survey of recent fellowship graduates, where a trainee is willing to live is an overriding concern. I do not believe that market forces will resolve this problem in the end. The number of fellowships has risen dramatically, and the distribution remains the quality of the academic jobs available. I worry that if our graduates cannot find work where they want to live, we will no longer attract the best and the brightest to the field. I think bigger, more innovative changes are required. For example, I would consider putting less emphasis on the 2 years of research during residency, keeping it only for those truly inclined to pursue research later. And we should not require it for an applicant to match. Instead, I would advocate for taking those 2 to 3 years and placing them after fellowship, an extended version of what Dr. Brandt proposed. Graduates would be required to serve in underrepresented areas for 2 to 3 years, and then they would have the choice to practice wherever they wish. This would ensure a pipeline of pediatric surgeons to these areas. The Right Child, Right Surgeon manuscript advocates for increased use of telemedicine. However, I asked the panel to expand on other novel solutions they envision, or if they truly believe big changes aren't necessary. Anyone can begin.
Sam, can I begin with one request of us? If we use the term requirement, anytime we put that out there as a statement, can somebody please clarify who has the authority to make the requirement? we need to live in the real world of what we can do. There's not a requirement for research. It's simply that you as a program director and I as a program director and Mary as a program faculty choose those applicants. Well, I think what we need is culture change. We need to value surgeons that practice outside of academic medical centers. They need to have leadership positions in APSA. They need to have leadership positions in the Pediatric Surgery Board. And we need to be proud of those applicants or our fellows when they go out, that they can stand alone in Kansas rather than joining a faculty that already has 20 people. And we can do that with cultural changes. We're actively seeking consultants for the board that come from these sorts of practice. And we see those changes in APSA. And as we change the culture, we'll change the culture of who we match and where our applicants go.
Add to that, I agree with you. I think, the more I'm playing with this idea of the Operate for America program or whatever it is so interesting, right? That all of our fellows are passionate about global surgery. I mean, it is part of the culture of the current generation of surgeons that caring for the underserved is part of their platform and part of their being. I don't think it's going to be a big stretch. And I agree with you, Doug. No one can require it. But I think that saying, maybe everybody does 3 years and that third year is somewhere underserved with the faculty backing you up by telehealth. I don't know. We can just brainstorm about it, but I think we can take care of we can think about this in the context that our fellows really want to do this kind of thing now. I don't think it's going to be a hard sell.
I'll add on here. I think that both Doug and Mary are correct. I do worry a little bit from my prior military experience that if we don't do more from a leadership standpoint, that our applicants will erode. These individuals are very smart. As a leader for the first year medical students asking me what the case mix index would be when they graduated, I was trying to remember the Krebs cycle. They're asking me what their life is like, right? And they're doing it. They're very smart. They know what they want. They know where they want to go to. And so we have to understand that many of them don't want to go into a rural surgery pathway. And if that is where they're going to end up seeing themselves, that may change their outlook on becoming pediatric surgeons. And so I agree with Doug, though, that we need to encourage and start looking early on for the right mix of individuals. We need to recognize and be transparent that you may have a job and it's okay to not do a lot of tracheoesophageal fistulas, diaphragmatic hernias, those sorts of things. You're going to do because you're still providing care for children. And that is what we're looking for. Individuals who want to provide pediatric surgical care across the country. But that's on us. And that is our leadership role to be transparent about that and mentor the right people from that standpoint.
So if I might add to that, it's more of a rhetorical question, is where's our responsibility with regard to training general surgery residents? So we're talking about training our pediatric surgery fellows to go into rural spaces or places to practice. Are we moving away from our commitment to training general surgeons to do basic pediatric surgery if there's no pediatric surgeon around? And I said this would be rhetorical. I think that we have to embrace a greater commitment. I think that we should emphasize to the board a greater need for surgery residents to spend more time on pediatric surgery residents. In our program, that time is truncated. Now we only have third-year residents who spend only a month, where we last year had two fourth-year residents spend 2 months. And I don't think those third-year residents are leaving our service understanding when they're done how to take care of children.
I agree with you, Ed, but we didn't drive the general surgery residents away. Their program directors took them away because they had other areas they wanted to emphasize. So I think that begins with us making a case to the general surgery program directors that this is important for all residents or is important for a subset of their residents. And I think as those residencies evolve, that will impact what we do.
Some of it also, though, let's be honest, is about the finances that pediatric hospitals, like all hospitals, have a cap, and probably half of the residents are being funded through the federal dollars. And they're they're preferentially going to go to pediatric residents and not surgical residents, just by the power dynamics of most children's hospitals. So I think it's a complex thing that we just need to shine light on all of those little aspects of this.
So thank you all for your answers. And I want to thank everyone who is contributing to the question and answer chat online. The questions are wonderful and we could spend hours on each one of those. But for my next question, I'll start by saying I think it's very clear that everyone is in agreement that all children deserve quality care by a competent surgeon. And where you differ is how do we make that happen? And this is an oversimplification of the underlying issues, but we seem to be looking at three approaches. We either bring the patient to the surgeon, we bring the surgeon to the patient, or we create new methods so that we have more surgeons who can provide care for specific problems in underserved areas. But we've been concentrating on the training. So I want to ask you, are there other approaches we should be looking at rather than focusing on our training models? Is there a role for advocacy through legislative or administrative changes at the local, state, or national level? And if so, where do we begin? I didn't expect silence.
No, I'm trying to think, like, what would you advocate for? I'll throw it back to you, because I think that's kind of fascinating, and particularly right now in the climate that we're in, the climate of change towards equity, which I think we all are very hopeful for. Is there a role for saying, let's figure out the finances from federally paid insurance? I mean, who knows where we're going to be a few years from now in terms of coverage, et cetera. But maybe, yeah, I think that's an interesting idea.
But go ahead, Dr. Barksdale.
No,
Sir.
go ahead, Dr. Weekend.
Well, I think you need to advocate as well to our colleagues in other specialties. I think this is not necessarily a thing that we can attack and accomplish on our own. We have not only other pediatric subspecialists that are out there that are facing the same thing. We have a dearth of general surgery and medical coverage in rural America, and so we need to advocate for rural America as a whole. And include anesthesia support, include our nursing support, our ancillary services. Those are the things that we need to look at. And I would argue we need to advocate as well as APSA to understand where we are providing care. I have looked at a lot of these numbers over the years of where we have pediatric surgeons, and I have a grasp of all of the coverage we are providing across the country. And so I think taking a second, regrouping ourselves as a body of pediatric surgeons and saying, where are we providing coverage? Where is a true needs analysis to be done is beneficial.
Dr. Martin, thank you for your comment. I had mentioned at the end of my comments that I do believe this is an advocacy issue, not just with the 1,500 pediatric surgeons, but with rural communities and with state and local officials. This isn't, we can't be the tail that's wagging the dog. This has to be a need expressed by communities. We have our fiduciary responsibility to the public, I think, as physicians. And as mentioned, not just surgeons, but as physicians and health providers. So I think strongly this is an issue that is beyond us that we can connect to.
I want to make a confession. I am a part-time pediatric rural surgeon. And I would say one of the groups to advocate with is your own health system. Our pediatric surgery division, which is an academic division, provides full-time pediatric surgery coverage in Montana. And we do that just like you rotate onto our own service. So there's continuity of care between our partners. And that's a partnership that's between our division, our children's hospital here, and a hospital that is not a part of our health system to create a system to provide that care. And quite honestly, it's a system that we're all very satisfied with as surgeons. It's a quieter week. We maintain our competency by doing complex cases in our main hospital. And there's a pleasure of being the surgeon that goes in and sees a child at the bedside with no resident, no nurse practitioner, and sit on the bedside and and enjoy that. So I think there are creative solutions, and you need to look creatively at who the partners are. Our Children's Hospital is interested in having us there so that the complex cases come here rather than go elsewhere. So I think there's a wide range of groups you can advocate with.
To dovetail on Dr. Barksdale's earlier comments, I have a question that's not rhetorical. Until we are able to ensure access to pediatric surgeons for all children, what responsibility does APSA and our specialty have with regard to the care currently provided to children in underserved areas by general surgeons? Should we train general surgeons as best as we can?
Yes, better than we are now, I would say.
Undoubtedly, yes. I agree wholeheartedly. We should be doing more. And I have residents at a rural community hospital that ask me all the time, how can I be better as a general surgeon? And they want to get involved.
I absolutely agree. And we train our general surgery colleagues not only as residents, but as professional colleagues. You know, we live in an area that's remote, and I have talked general surgeons through malrotation operations with volvulus when the conditions prevent transport. So I think that collegiality and network is what we do. We're specialists. We're a resource to the community, and we're a resource to our general surgery colleagues.
And I will dovetail on that because, you know, as I said, it's not either or, it's both and. The issue, none of us disagree with any of this. The issue is the view that they are our competitors, and that we often debates and at an administrative level, not physician level, about who's providing what care to who because of the money that's involved. And so I wholeheartedly think that this view we're articulating, that it's a network of care, that we are at the top with our expertise, but that doesn't mean our hands have to actually go on every single patient, but we have to make sure that we're available to talk the general surgeon through the malrotation or to accept the patient and get rid of the idea that we're all competitors.
Thank you. So stepping back a little bit, considering Dr. Barksdale's admonition that we avoid being too paternalistic in our approach, where do the patient and family preferences fit into this discussion? The reality is that the family's options are constrained by their particular payer and or other social circumstances beyond their immediate control and beyond our immediate control. But they may also be affected by a lack of understanding of the critical arguments that have been made here today. So how do we engage families in the decision-making process? And should individual families have the option to decide what is more valuable to them, i.e. location and care close to home versus a surgeon with pediatric expertise? Should they be able to choose the risks and costs that they are willing to bear in any particular situation?
I'll make two plugs here. Absolutely, the family should be able to make the choice, and they should be able to make the choice in a way that's informed like you or I would. And our professional responsibility comes in to identify those. And there, two, I think board certification is one. We need to have people understand what that training means, what the scope of it is, and what's involved in that. And the other issue is the resources of the institution. It makes a difference if they're getting a pediatric anesthesiologist or not. It makes a difference if they have a pediatric respiratory therapist. And that's the rationale that lies behind the American College of Surgeons Children's Surgery Verification Program. And we are keen to have centers that are going to be level 3 and level 2 enter so that families will know the scope of practice and the capabilities of these more rural hospitals. Families should be able to make a decision, but they should be able to make an informed decision.
You know, I agree with that as well, that the families should be making informed decisions, and we should guide them in their decisions. But we are very paternalistic in how we set up children's surgery centers, how we set up the different practices that are available to them. We just looked at ECMO centers. ECMO centers are not set up around the country in a uniform pattern. And so there is significant disparity in care in individuals and children that can receive ECMO. And does that change the way a child is managed in different parts of the country? Now, we didn't ask that question, but it starts to make you wonder, is a child in a small rural area provided the same opportunities as somewhere else? And they may not be because of distance to care, travel to care. And so when you put that in the family's lap, of course, they're going to want everything that is capable and available to them. But we have to be able to explain that to them. And I think that's where we as pediatric surgeons and leaders, we have to be able to look at ourselves in the mirror and make sure that we are doing everything right for every child possible. Clearly, there are financial constraints and there are other constraints within the system that we have to deal with. But we need to be able to look at ourselves every morning and say we're doing the right thing for every child.
I think sometimes we forget that it really is the structure of our healthcare system that is leading to a lot of these issues. And the next time we have this debate, you know, if we had a French surgeon, some of our Canadian colleagues, if you have a universal payer system, which I know has been like a bad word in American medicine for decades, you do start making decisions based on public health needs rather than financial needs. And I think we just have to say that. And we have to realize that if we're putting ECMO in because it makes a whole lot of money and it's going into really big centers, that's the outcome, is that there's places where people don't have money, don't have the coverage, and the ECMO center is not going to be put there.
So Mary?
Sorry, I had to unmute. Yes.
Yeah. Are you still a resident of Texas?
Yes.
Then I want you to.
Yeah, I do not want to discuss my state.
I want you to run for Senate. I want you to run for Senate so we can begin to change those states, because these are very important issues, and I think that we're much more aligned than it may appear. But I honestly believe that these are government, social, legislative issues that we have to change if we're going to change the way our country thinks about equity in healthcare. And some people might say that if you choose to live in a rural area, then that's what you get by living in that area. I'm saying some people might say
that's the libertarian view of medical care in the justice system, and it's not one that any pediatric surgeon I know subscribes to.
And I know Dr. Barksdale doesn't agree with, doesn't believe that either. But you know, it's true, right? Some of these people live in rural centers and need to be there. They're the farmers, or the people that provide everything we need in a country and our sustenance, right? So how can we not provide better care for them?
Please don't be confused. I wasn't saying that. Okay. Some people believe that. And so that's why it has to be changed at a much higher level for us to move forward.
I think it goes back to Dr. Martin's comment about what role advocacy has, and that, you know, these social systems actually make the biggest impact on the thing we're discussing.
So we have a few minutes left, and I was going to try to entertain some of the questions from the Q&A list. A lot of the topics that have come up we have touched on, so I will try to pick a couple that are slightly different. So I'm going to start with this one. Will any fellowship training programs voluntarily train fewer fellows? Should we temporarily reduce the number of fellows trained for a few years?
Well, I can tell you, Kevin Lally made a heroic effort to promote this several years ago, and the net effect is zero. And my conclusion of that was, it's like global warming when you look for voluntary control. And I've told Kevin in the past, be prepared to live on a hot planet that has a lot of pediatric surgeons. It may sound cynical, but I think that voluntary action is not going to do it. And I don't think that there's any group that has a regulatory authority to do it.
You know, it's interesting. It really goes back to Jay Vacanti's really remarkable discussion, right? Of how acting as an individual or an individual hospital, you obtain power one way as opposed to collectively. And I think what we're talking about right now is collectively as a society, what do we do? But in the meantime, you have the hunters rather than the gatherers who are accruing success individually. And it's really kind of that simple and kind of that hard, because you're right. It's hard to break that. That's human nature.
Yeah, I think unfortunately we're going to be seeing what Doug touched on before is the market forces driving this, and we're going to have potentially less applicants and less qualified applicants, and maybe there'll be spots that don't match. And are we going to be headed that way? And that may be the driving force eventually for looking at fellowship programs that will go away, because for 2, 3, 4 years they don't have anybody matching. The institution will look and say it is not worth it at this point to continue on with this. So I think right now, given the current landscape, that is probably what is going to drive it most. And I am concerned, though, that is probably where we are headed, given the case mix index and how things are going. And
we've done that experiment before, though, right? In cardiac surgery, and we went through a period of time where we had some very badly trained cardiac surgeons and issues. And I think that's the thing we have to be honest about, that if market forces drive it, it's going to hurt quality.
So I want to say something that's not too self-serving or arrogant, but after I watched the plenary session this morning and the surgical outcomes, I think we have to be a lot more optimistic in that. There were some powerful young pediatric surgeons and pediatric surgeons to be, and most of us are attracted to fields not by just what we do with our hands, but who we do it with. And I think that the future is quite bright. We may be the old guys and girls, men and women, I'm sorry. But I think that people are evolving, doing innovative things. They're putting pediatric surgery on the cusp of technology, on the cusp of technique, and on the cusp of humanity. And the best and brightest will always go toward that. So I think that we have to be aware of these workforce issues, but I think that we're still going to attract the best and the brightest.
Amen, Ed.
My next question has to do with the training experience at fellowships. And there's several questions that are along the lines of asking the panel to discuss the variation in training of fellowships and the fact that the exposure to index cases in training seems to be decreasing as well.
If I can just interject some facts into that. Actually, the exposure to index cases is not decreased in the applicants for board certification, and in fact, this is the first group of new board certification candidates that actually have a minimum case requirement. So everyone that's a member of APSA did not have any minimum case requirement broken down by your categories to become a pediatric surgeon, and our new graduates have that. So interestingly, the case mix is remained good, and the issue is when you graduate that your case mix does not reflect what you did as a pediatric surgery fellow often. But the training mix is good, and we actually are for the first time requiring a specific distribution of cases. And hats off to our APSA president, John Waldhausen, who really, along with Ken Azra, drove that effort in the Pediatric Surgery Board that was then brought to fruition by Marge Arca.
All right, and then I think we probably have time for one more question. Let me, so one topic that has not been addressed yet, and actually it's specifically to you, Dr. Barnhart. Can you comment on any parallels to surgical oncology that has lifted both fellowship and general surgery?
I'm sorry, can you restate? I'm not sure I understand. So surgical oncology, you're correct. They've identified their board as complex general surgical oncology is how they describe their board. I'm not sure that it's distinctly different than ours, other than the fact that obviously we're a bit more population-based and they're disease-based. I think, again, they would argue that sarcomas shouldn't be done by general surgeons, even even if it is listed in their board background. So I'm not sure I'm capturing the true spirit of what the person's asking the question is asking, but I'd be happy to take that as an email if I missed the point of it.
I think if I can add, I suspect it's that, general surgeons still do the vast majority of cancer surgery in the United States. And if I understood that idea, it's if we took that same model, it would basically answer a lot of the questions that we're talking about, that we become the complex pediatric surgical care and general surgeons care for the other stuff, I think.
And we are unfortunately out of time, but this discussion will continue in the town hall later. In closing, Dr. Martin and I would like to thank our outstanding panel for their time and energy in delivering such thoughtful and passionate arguments. We would also like to thank Dr. Waldhausen for putting this topic front and center on the program. This is a provocative subject for which we as a specialty do not yet have consensus. That is clear. But I believe the issues debated today have been neglected for far too long, and I hope this symposium will be a springboard to further discussion, refinement of the next steps with broad consensus leading to action. Thank you.
Thank you.
Thank you so much. What a great group of co-hosts. I just appreciate everyone's effort, and what an informative day. Thank you.
Just a reminder to everyone that tomorrow, Saturday, we start at 10 o'clock for members because we have the annual business meeting that starts at 10:15 and the town hall that starts at 11, which ends at 11:40. And then for everyone who's joining APSA meeting this year, the plenary session 2 starts at 11:40. Again, APSA members start at 10 o'clock, the timeout. 10:15 is the business meeting. 11 o'clock is the town hall. And then at 11:45 starts the all-inclusive meeting. So great day, everyone. Thank you very much for joining APSA 2021. Thank you for allowing us to be your moderators today, and see you tomorrow.
Thank you so much.
Thanks, everybody.